Overture resurfacing of a chronic medial femoral condyle cartilage focal defect and medial meniscus root repair. Focal chondral or osteochondral defects are common within the knee. These pathologies can be painful and disabling, have a poor capacity for repair, and may predispose patients to osteoarthritis. A majority of focal chondral defects are found on the medial femoral condyle. Addressing these pathologies can be challenging, and several factors should be taken into consideration when developing a treatment plan, including patient alignment, degree of osteoarthritis, as well as the size and location of the defect. The treatment algorithm follows a cascade that includes both simple high-frequency and complex low-frequency procedures, which range from debridement, microfracture, osteochondral autologous transplantation, autologous chondrocyte implantation, osteochondral allograft transplantation, and unicompartmental knee replacement. A new focalplasty technique, overture resurfacing, is composed of femoral and tibial implants that allow the surgeon to replace only the diseased or damaged region of the joint while preserving healthy surrounding cartilage and meniscus. For our patient, preoperative radiographs of the right knee were obtained. AP lateral and sunrise views demonstrated a medial compartment bipolar osteochondral defect. Preoperative MRI also revealed an intact ACL graft, a complex degenerative medial meniscus tear with subluxation, and a medial femoral condyle cartilage focal defect with edema. A medial parapatellar incision was made, and high anterolateral and anteromedial ports were created. Grade 4 changes were confirmed in the medial compartment on the tibial side as well as the medial femoral condyle. A full thickness root tear was also identified. The root tear was addressed first and repaired using the transtibial double tunnel pull-out technique to enhance stability and anatomic restoration. To begin resurfacing, a medial parapatellar arthrotomy was made. The retropatellar fat pad was removed and the anterior root of the meniscus was detached to gain access to the proximal medial tibia. To start the tibial implantation, the base of the tibial guide was placed flush to the tibial surface and the guide pin was drilled into the tibia until the laser mark reached the top of the guide. Next, the primary tibial reamer was placed over the pin and reamed until the hard stop contacted the tibial surface. The secondary tibial reamer was then used to hand ream over the pin before the tibial trowel implant was inserted into the cutout to assess fit. Then, the peg drill was inserted into the hole created by the pin and drilled under power until the shoulder on the bit contacted the bone. A pea-sized amount of cement was applied to the central drill hole, and the tibial implant was placed into position and seated with the tibial impactor. These steps were repeated on the medial femoral condyle for femoral implantation. However, given the large area of the defect, we decided to use an oblong implant. To begin, the femoral oblong pin guide was placed over the defect and the guide pins were driven into the superior and inferior holes in the guide. Next, the femoral central reamer was placed over each pin to ream until proper depth was achieved via the hard stop at the base of the reamer. The femoral secondary reamer was then used to hand ream over both pins until the reamer was recessed approximately 0.5 millimeters below the adjacent cartilage level. The guide pins were removed and the oblong femoral trowel was introduced into the reamed cavity to confirm fit. The femoral reamer guide was inserted into the reamed implant defect. Then the reamer was placed through the round port and driven until it reached the built-in stop. The peg drill was inserted into the holes created by the pins and drilled until the shoulder on the bit contacted the bone. Cement was applied to each central drill hole and the femoral oblong implant was placed into position and seated with the femoral impactor. To reattach the anterior root of the meniscus, knotless anchors were utilized to tack down the meniscus back to the anterior portion of the knee. After this, a layered closure was performed using 2-0 and 3-0 monochrome. Post-operative protocol follows immobilization in a hinged knee brace locked in extension for 6 weeks with non-weight-bearing status. At 6 weeks, the patient is transitioned to an unloader brace. Weight-bearing is tolerated and progressing in range of motion and strength.